Definition of a surgical complication هي any deviation from a normal post-operative pathway. Okay, you expect your patient to have the surgery, to have the typical post-operative pathway according to the instructions, that the wound heals, the anastomosis heals, and the patient goes on with the normal pathway. Any deviation from this pathway is called a complication. The severity, there are several classifications of surgical complications. Okay, it depends on the severity. The most commonly used is Clavin-Dindo classification. They classify the wound the complications into grades from 1 to 4 or 1 to 5 according to the severity. What is the best way to manage complications is to prevent these complications. Prevention of these complications, they usually start from the preoperative assessment. You have to have a good preoperative evaluation, starting with deep history, detailed history, and physical examination, identifying of any comorbidities, optimizing the patient comorbidities, and management of any medical issues that would raise the risk of possible deviation from a normal pathway. Nutrition is one of the most important pillars and the most important component of the management of a surgical patient, because whatever you do surgery, it wouldn't give a good outcome unless the patient has adequate nutrition. Sometimes you may need to postpone the surgery or to delay the surgery to correct the patient's nutritional status. Minimizing preoperative hospital stay. In the past, the trend was if a patient going into a major surgery to admit them several days or even a week before the surgery to have the preoperative assessment, preoperative optimization. But now the trend is now to do all of these preoperative assessment, preoperative optimization and preparation and images as an outpatient, on an outpatient pathway, okay, to minimize the hospital stay, because the more your patient stay in the hospital will be the higher risk of developing nosocomial infections or hospital-acquired infections. So minimizing the stay. هلا الناس صارت تعمل major operations, whether they major GI surgery, major cardiac or vascular. They usually admit the patient at the same day of the operation to decrease the risk of nosocomial infection. Good surgical technique with minimizing the tissue dissection, adequate hemostasis, adequate amount of hydration, okay, the right amount of hydration. That's all can be counted on a good surgical technique that would help to decrease the risk of complications. Early ambulation will definitely help your patient to fasten the healing, to put them back on the right track, to go back to their baseline or close to the baseline as much as they can be. Talking about the complication, when you talk to your patient, when you take the consent, when you explain the operation, usually explanation or counseling about an operation will never be complete unless you mention the possible risks or the possible complications that may happen. As we said that in المحاضرة السابقة. Usually when you tell your patient, if your patient asks you or you tell your patient about the possible complications, you need to classify them about general complication and specific complication. General complication that may happen in any type of surgery, like what? Does everybody have? Yeah, sorry? Bleeding, excellent. Infection, wound infection, yeah. Yeah. We're talking about abdominal surgery that may go more with the specific complications. General complications, into take it as a habit. The general complication that whatever surgery you do, pain, bleeding, infection, internal to organ injury, need for further procedures, this may happen in any type of surgery. And then you go to the specific complications according to the type of surgery. For example, cholecystectomy, you may add biliary tree injury, slipped stones, post-cholecystectomy syndrome, convergent to open. In bariatric surgery, you may include risk of leak, risk of PE, risk of acid reflux or dysphagia, failure to lose weight. It depends. So you have to divide the explanation of your patient into general complications and specific complications, right? What is the most common complication of the certain type of operation? You have to know. Whenever you are specialized in a certain branch of surgery, you need to know what are the most common according to the literature, according to your local policy, local statistics. What are the most common complications that may happen? You can never tell your patient that risk of complication is zero. You need to be open and honest with your patient because that's his legal right. Okay? You can't decide. You may explain the risk of a complication and the patient decide not to go through this surgery. Okay? If the patient would know that he may die with a knee replacement surgery if he's extremely high risk, he may opt to go to complete his life with osteoarthritis or some limitation of movement rather than going into a knee surgery. You need to share the decision with your patient. So the decision maker whether to go into the surgery or not is the patient himself first, and then you help them to take the right decision. You can't take a decision on behalf of your patient. That's why if he's the decision maker, he needs to know everything about the surgery, including, and one of the most important things are the possible complications, right? Most common complication, according to the literature, according to your knowledge, according to your local statistics, you need to tell your patient about the most common complication, even if they are simple, okay? And the most serious complication. If there is a possibility that this patient may pass away after the surgery, they need to know. If there is a high risk of mortality, the patient or his family or his next of kin, they need to know about this risk. What comorbidity does the patient have? As we said, in your assessment for your patient, you need to know what medical illnesses does he have, and if we can optimize these, or if these comorbidities would increase the risk. And as an overview, we can divide the complications into immediate post-operative or care during the patient, the post-operative care in the ward, or continued after discharge. Right? These are short-term, immediate, short-term, and long-term complications. General classification, you can classify the complications into wound, thermal, post-operative fever, pulmonary, cardiac, GI, metabolic, or neurological complication. As we said, complication, it represents any deviation from a normal pathway of a post-operative care. Wound complications, that would include dehiscence or evacuation, or wound infection, seroma, hematoma. We'll come to that in details. Dehiscence, that's a dehiscence, that's separation of the wound edges. That the wound edges, you suture the wound at the end of the operation, the next day or so, or after, you observe that the wounds are not coming together. There is a separation, there is a distance in the wound. The dehiscence may happen at the level of the skin, at the level of the subcutaneous tissue, or at the level of the fascia. One of the serious consequences of the evacuation of the dehiscence is evacuation, which means protrusion of the intra-abdominal content outside the body. Okay, that would need an immediate intervention. As we said, other type of wound complications such as seroma, hematoma, infection, or as a long-term complication, they may complicate with incisional hernia. Okay, this picture represents an evacuation, okay, which protrusion of the bowel. This would need an immediate action by taking the patient back to theater. You need to cover it with a wet sterile gauze and take the patient to cover. You can't leave them because they will dry, they will ulcerate, they will develop a leak or a fistula. This picture represents seroma. Seroma, by definition, is a collection of fluid. This fluid can be liquefied fat, serum, lymphatic fluid, and accumulate usually under the incision, because sometimes you cannot control all the leak. And the microvascular structures, it's a very tiny lymphatics, they may continue to leak under the wound, under the skin. Usually it's a benign condition. Usually it's a self-limiting condition. So you don't need to intervene in most of the cases unless they're causing pressure effect or they're bothering the patient with the cosmetic appearance or they're staying for a long time after the surgery. Usually they are, as we said, benign. There's no erythema or tenderness. If they are accompanied by erythema or tenderness, that would mean it's an infected seroma or an abscess. Usually there are some certain types of surgery that they may have more incidence of a seroma, such as mastectomy, axillary or groin dissection. You can notice here that these surgeries, there are lots of dissection in the fat and a lot of dissection in the lymphatics. That's why there is an inevitable amount of leak from the body fluids and the lymphatics. Treatment, usually in most of the cases, it is conservative. If you need to intervene, you may aspirate or evacuate or put a suction drain if you need to intervene. The next form of body fluid collection is a hematoma, which is the term is self-explanatory. It's a collection of blood under the skin or in the wound in the surgery field. Okay, it may collect at the gallbladder fossa after cholecystectomy. It may collect inside the abdomen. It may collect under the skin. Okay, it may collect at the site of fracture after orthopedic surgery. This is a collection of blood. Usually, if it is superficial, you may observe some discoloration of the skin, some erythema. It depends for how long has it been going on. That may change into dark color over the time. Okay, etiology, it depends on whether it is a patient factor or technical factor. Patient factors, patient on anticoagulation, patient on antiplatelets, they are more prone to develop bleeding and consequent hematoma. If there was imperfect hemostasis or slept ligature, they may develop hematoma as well. The biggest concern with this retained hematoma, the same with seroma, they may develop pressure effect, they may develop pain, and they may develop, unfortunately, infection, which will turn this into an abscess that will need intervention. Wound infection or surgical site infection, it varies from a superficial wound infection or deep wound infection. It depends on the severity. Superficial usually is just at the level of the skin or the subcutaneous fat. Deep wound infection, we're talking about body space or inside the abdomen or involving the muscles or the fascia. Usually, when do they present? Most commonly, post-operative wound infection, they happen between day 3 to 5 or 4 to 6. Unless it is a very virulent microorganism, they may present at day 1 or even day 0, but that's extremely rare. Usually the wound infection, usually if they're gonna happen, they happen in day 3 to 5. And what's the clinical implication of this? that احنا لما نلف round يعني بنشوف المريض ثاني يوم العملية. Okay, do you need to remove the dressing? You don't need to remove the dressing at day 1 or day 2. Okay, if you want to change the dressing, you change it at day 3, unless it is dirty. So if it is clean, you need to keep it because you're not expecting a wound infection before day 3. At day 3, you change the dressing to make sure that there are no wound infection. The presentation of wound infection, usually they may present with just mild erythema around the wound, some discharge from the wound, and if they are deep and severe infection, they may present with systemic manifestations such as fever, tachycardia, tachypnea, or the rest of the SARS symptoms. This is a sign of one of the most serious infections, which is called necrotizing fasciitis, which, by the way, does not necessarily need to happen post-surgery. It may happen in diabetic patient, an immunocompromised patient, even if they didn't have surgery. It is a severe, life-threatening infection in the deep, at the level of the fascia, deeper than the level of the skin. You can see the appearance, and even the skin. The skin may appear, the picture to the left, the skin appear erythematous, and the skin may look normal. but when you feel it, it's severely tender, and you may feel crepitus underneath. The picture in the middle presents a groin or lower abdomen necrotizing fasciitis with some manifestations of the skin, and the picture to the right represents a post-operative, the defect that was left after treatment of necrotizing fasciitis, which basically needs aggressive debridement. You need to take all the necrotic tissue out when you deal with necrotizing fasciitis. The most common organism following penetrating wound is group A beta hemolytic strep. Post-operative wound infection, when they develop necrotizing fasciitis, the most commonly it's a Clostridium myconecrosis. Usually the presentation, it is severe onset of pain at the site of the surgery. You may feel crepitus or edema or tense skin, or even the skin might look normal. In most of the cases, if it is in a diabetic or in an immunocompromised patient, it's a polymicrobial rather than a specific microorganism. As we said, the treatment is aggressive early debridement. هلا المريض هذا لما يجيك تقدرش تخليه للصبح. Okay, you need to intervene because it is a life-threatening condition with severe bad consequences. Complications on the level of the temperature, body temperature, it may go into the hypothermia side, it may go into hyperthermia side. Hypothermia by definition, okay, is drop to more than 2 degrees Celsius. Okay, so temperature is than 35, there would be a consequences on the coagulopathy, on the hemostasis, on the platelet function. That's why when you are in the theater, there are certain measures that we do to minimize the risk of hypothermia. شو بتشوفوا بالtheater? What do we do in theater to minimize this risk? Anybody? Yeah, go. Sorry? Yes. If you're gonna give IV fluid, which is usually the case, you need to give them in a close as they can to the body temperature through a warmer, whether they are fluid, medications, or blood. That's number one. Number two, what else do we do to minimize the risk of hypothermia? Because hypothermia, do not underestimate the risk of hypothermia, because it may start a cascade that will cause serious complications to the patient. Usually the temperature in the theater should be not too high, not too low. Usually a room temperature, a balanced room temperature would help the patient. The other thing that usually we use a warmer or bear hugger. You see a warm air going into a blanket that covers the patient except the field of the surgery. Okay, that would also help. In addition to frequent monitoring of the body temperature. If you're doing a major surgery or doing a long surgery or any type of surgery more than 30 minutes, any type of surgery more than minor surgery, you need to measure the body temperature. Okay, they put a probe either into the esophagus, down into the esophagus, or into the rectum. They take the core temperature of the body to see whether the patient is developing hypothermia or not. Hypothermia may cause cardiac event in the form of arrhythmia, increase the risk of surgical site infection, increase the risk of bleeding with the consequent use of blood transfusion, or increase the risk of hematoma formation. Hyperthermia, luckily, this is a rare disorder. It happens on autosomal dominant. It's an autosomal disorder. Usually the presentation is fever, tachycardia, rigidity, cyanosis immediately after the induction of the surgery. The treatment is dantrolene. So you have usually the patient, if they have a risk factor, you have to ask specifically about these risk factors. You have to ask if they had similar episodes before, if any family member had similar episodes. So you have to identify the patients who are at risk to prepare the theater and to prepare the anesthetist. Post-operative fever, What's the most common of the post-operative fever? Most common cause usually atelectasis. What is atelectasis? Collapse of the lower segments of the lungs. Why does it happen? Because the patient, when they are under general anesthesia, they don't take a deep breath. Okay? So they don't take a deep breath, they don't expand their lungs, there would be a chance of accumulation of the secretions at the lower zones on both sides. That's what happens inside the operation. Why would it happen after the operation? If they don't ambulate, if they have pain that would prevent adequate breathing or deep breath, if they have upper abdominal wounds, okay, they may try to avoid taking a deep breath, and that will predispose them to have atelectasis. And that's the most common, usually still in the literature classic teaching, this is the most common of temperature of fever in the early post-operative period. Okay, patient may develop fever later than that, and that would need a detailed assessment that may include history, physical examination, blood cultures if they are spiking a temperature, and assessment according to the focus that you think. If they have respiratory symptoms, you need to do a chest X-ray. After physical examination, you need to do urinalysis and culture. If they have urinary symptoms, send the sputum culture, and then treat accordingly, according to the focus of the infection. And this is, again, classic teaching for you to remember the most common cause of post-operative fever. هاي تعلمتوها يمكن بالintroductory course. Either it is a wind, wound, water, walking, waste, or wonder, something related to the medications. Pulmonary complications, as we mentioned, atelectasis is the most common one. Aspiration pneumonitis, nosocomial infections, pulmonary edema, and pulmonary embolus. You can see this X-ray. These are different X-rays for different conditions that may happen post-operatively. The picture on the right represents a pleural effusion. Okay, pleural effusion, you can see obliteration of the costophrenic angle. The opacity on the right that represent collapse of the lung, and the hemothorax on that side is filled with fluid. The one in the middle represents pneumonia. Okay, which type of pneumonia, if you know? Anybody? It's a lobar pneumonia. What do you think the underlying cause is? When it happens specifically in that place? We're talking about right middle zone. Aspiration, excellent. Aspiration. Patient may develop aspiration, number one, because under anesthesia, they don't have adequate swallowing effect. They may aspirate either during the operation or immediately after the operation. Okay, so they develop aspiration pneumonia. The picture to the left represents pulmonary edema. Pulmonary edema, you see something similar to the ground glass appearance. All the lung tissue are infiltrated with fluid. So why would a pulmonary edema happen to a patient post-operatively? والله يعني ارفع ايدك وجاوب عشان الزملاء يفتحوا. Why would the patient develop? Who's under risk of developing pulmonary edema post-operatively? What would cause pulmonary edema? Yeah. Patient with heart failure, excellent. Patient with heart failure, that's why we mentioned at the beginning of the lecture that you need to identify any comorbidities that your patient have, okay, and to optimize their condition. They may need to visit the cardiologist pre-operatively to optimize their condition. That's number one, that's pre-operative. Inside the operation intraoperatively, your anesthetist should be aware of this comorbidity. They have to be cautious with the amount of the fluid. They have to monitor whatever is going in and whatever is going out, and that we call, this is strict input-output charting, right? Okay. Post-operatively, if your patient is fasting and you need to give maintenance IV fluid, you need to be cautious not to overhydrate your patient and to give exactly just the right amount. Do not give inadequate amount. Do not give overhydration to your patient. That's why you need to be careful with this type of patients. Cardiac complications. There is a wide spectrum of cardiac complications that may happen to the patient post-operatively, and patients who are under risk are the patients with risk factors for cardiac comorbidities such as hypertension, ischemia, infarction, okay, patients with arrhythmia, elderly patients. They need to have proper assessment, starting with history and then followed by physical examination and the proper investigation. You have to identify your patient. You have to have a high index suspicion of cardiac comorbidities if the patient has several risk factors, right? Renal complication, again, renal complication may happen during the operation or after the operation. If the patient has a borderline kidney function, okay, if they received inadequate amount of hydration, right, they may develop renal failure. And that renal failure you need to manage according to the classification, according to the type of renal failure, whether it is renal or prerenal or post-renal. One of the most common causes of post-renal failure is urinary retention. They develop obstruction. Which group of patients are more at higher risk of developing urinary retention? مين المرضى اللي انت بتشيك عليهم ثاني يوم او بنفس يوم العمليه وتتاكد you have to make sure that they passed urine? Anyone? Sorry, gastric? Prostate. If you do a surgery for prostate, benign prostate hyperplasia or prostate cancer, any urological surgery, you need to make sure according to the post-operative instruction. But usually they have a Foley's catheter. This type of patient usually have a Foley's catheter. No, a general surgical procedure that you need to be aware of this possibility. Yeah. No. I'm talking about certain procedures, not a group of patients. شوفوا groin surgery, such as hernia, okay, especially if it is open, they may develop urinary retention. Anal or perineal surgery, they may develop urinary retention because pain in that area will stimulate sympathetic input, okay, and that will be presented as urinary retention. يعني مريض عنده عملت له hemorrhoidectomy، مريض عملت له sphincterotomy، مريض عملت له perineal abscess drainage. Okay, you need to make sure at the same day that they passed urine. Okay, you need to make sure that they don't have urinary retention. The same applies to the patient with open inguinal hernia or groin hernias. GI complications, they may vary from a simple post-operative ileus to GI bleeding or pseudomembranous colitis, anastomotic leak, or fistulae. Post-operative ileus. What is the definition of post-operative ileus? It's a non-functioning, lack of the function of the bowel. They just go lazy. If there was, during the operation, if there was excessive manipulation of the bowel during surgery, they may go lazy for a couple of days afterward. In most of the cases, it's a self-limiting disorder if you correct the underlying causes. يعني إذا عملت عملية لحد عنده bowel obstruction, you did a laparotomy, you manipulated the bowel, okay, they may go lazy for a couple of days or so, okay, and if you correct the underlying conditions, the patient usually, they resolve and they start to pass flatus or pass stool after day 2 or day 3, okay? How do you assess your patient? Usually the patients they have abdominal distension, they are unable to pass flatus or stool. If you do an X-ray, you can see there are several air fluid levels. I have a picture. ممكن يكون أوضح. Hi, multiple air fluid levels or dilated bowel loops. And this represents a bowel obstruction. Bowel obstruction may be functional, as in the case of ileus, and it can be mechanical if there is a stricture or adhesion. In the ileus, that may happen post-operatively in abdominal surgery. You just need to observe the patient, to hydrate them, to keep the NG if there is a high output or there is a vomiting, and to correct the electrolytes. What are the most important electrolytes to be corrected in the case of ileus? Potassium and magnesium. Usually it is associated. Hypokalemia, hypomagnesemia, usually they are associated, more likely to be associated with ileus. Early ambulation may also help patient with ileus. GI bleeding, it may happen from a patient anticoagulation or a stress ulcer. Okay, so you need to know who are the patients who are at risk, and if your patient is going to the ICU, if your patient is fasting for a long time, you may need to start them on antacid medications to minimize the risk of the ulcer. Pseudomembranous colitis, that's an infection of the colon, superinfection of the colon, usually due as a consequence of use of the antibiotics. So the antibiotics that you use may affect the flora in the body, okay? And it may get complicated with toxic colitis, which is a surgical emergency and a life-threatening condition. This CT represents the picture. As you can see, there are, in the picture to the right, there are thickening. You see where the arrows are directing? Thickening of the colonic mucosa. This is not the normal appearance. This is a thickened colonic wall and mucosa. You can also see some air locules from secondary to a perforation into the bowel in the picture to the left. So we try to use the antibiotics only in the right time, for the right period, and the right indication. If your patient doesn't need antibiotics, you need to stop them. Ischemic colitis may happen in certain types of surgery, like aneurysms, such as abdominal aortic aneurysm, if you dissect around the colonic vessels, okay, or in the colonic surgery. Surgical devascularization, hypercoagulable states, or hypovolemia or emboli may cause ischemic colitis as well. Anastomotic leak or fistula, usually if they happen if the joint between the bowel and wherever the anastomosis that you do, sometimes you may need to do esophageal anastomosis, esophagogastric anastomosis, bowel-to-bowel anastomosis. If they don't heal in the right way, the patient may develop leak. The leak may vary from radiological leak, which is a self-limited, to a clinically evident leak that would need an operation. So the management depends on the severity, depends on the site, depends on the status of the patient. Anterior cutaneous fistula, usually it is another form of leak, but it will happen at the long term, that the joint has leaked, or a missed perforation has leaked, or a repair of a bowel injury has leaked, and it found its way to the skin. So it formed anterior cutaneous fistula. This is a complex and challenging type of complications. Metabolic complications. There are several types of metabolic complications that may happen. Adrenal insufficiency. The adrenal gland is one of the most important in the body that keeps homeostasis. So it's not uncommon for patients to be misdiagnosed or miss their doses of cortisol. Why would adrenal insufficiency happen? If the patient is on cortisol, if they go into a surgery, the stress of the surgery, if they don't receive a stress dose of cortisol, they develop a full-blown picture of adrenal insufficiency. If they are undiagnosed adrenal insufficiency, and usually they are potentially lethal, unfortunately, they present with hypotension, cardiorespiratory collapse, and the electrolyte status, usually they have hyponatremia and hyperkalemia. So it's simple. The best way to manage this is to prevent it from happening with a detailed history. Hyper or hypothyroid, usually we have, if there is any risk factor or if there are any symptoms or signs of this thyroid, this need to be addressed before the surgery and to be managed in advance. SIADH, as you all know, it is a symptom of a syndrome of inappropriate antidiuretic hormone secretion. You need to see whether the patient has any risk factors to develop this, because they may present with a full-blown picture post-operatively, especially if they have a neurosurgical procedures or cranial surgery. Neurological surgery, you need to identify who are the patients at risk of neurological complication. Patient with atherosclerosis, patient with carotid stenosis, patient with a history of stroke, patients who had uncontrolled hypertension or who are on anticoagulant, they may develop. So you need to optimize your patient, to identify the risk factor, to communicate with the anesthetist, to explain the risks to the patient. Bleeding or hemorrhage, this is one of the most commonly recognized complications post-operatively. Okay, it will happen with any surgeon at least once or twice or more than that during his career. It is classified usually, it depends whether it is due to patient factor or surgical factor or technical factors, right? Patient factor, patients who have hypercoagulation or coagulopathy, who are on anticoagulants, who are on antiplatelets, are at a higher risk. Okay, surgery that would involve vascular surgery has definitely a higher risk of developing bleeding. Surgery who has a lot of dissection around vascular structures, they may develop bleeding. You classify the bleeding according to the timing, either immediate or reactionary, or early postoperative or secondary postoperative. Immediate, that's usually due to a technical error, technical factors, such as inadequate hemostasis or unrecognized damaged vessel. Early postoperative, either to clotting factor deficiency or slipped ligature or intraoperative anticoagulants. Secondary hemorrhage, it may happen later than several days, and that usually probably it may happen due to an infection. يعني I remember a patient who had برا في المكان اللي أنا دربت فيه, patient had subtotal gastrectomy. Okay, this was complicated by a duodenal stump. Did you imagine subtotal gastrectomy? Subtotal gastrectomy, you take the stomach and you leave a cuff of the stomach, you join it to the bowel, and you leave a duodenal stump. His surgery, unfortunately, was complicated with a duodenal stump leak that was treated conservatively. A week later, we were called for the patient because he collapsed in the floor with severe upper GI bleeding. And what was found, we took the patient to the theater. Okay, he survived. Fortunately, he survived. We found that he developed an abscess at the duodenal stump that eroded into the gastrojejunal anastomosis and eroded into the common hepatic artery. See, that's why always late post-operative bleeding, usually you have to rule out infection or abscess formation that eroded into a vessel. Okay? Thank you. Any questions? يعطيك العافية.